So in Module 2, we'll be talking about carpal tunnel syndrome. Upon the completion of this model, the student will be able to describe the etiology of carpal tunnel syndrome, including lifestyle and risk factors. They will be able to understand the possible signs and symptoms presented by a patient with carpal tunnel syndrome, and they will be able to outline the possible procedures, tests, and imaging techniques to accurately diagnose a patient with carpal tunnel syndrome. And lastly, they will be able to understand the conservative and surgical options for treatment of carpal tunnel. So here we're going to talk a little bit about the etiology of carpal tunnel syndrome. So it is defined as compression of the median nerve in the carpal tunnel. And the pathophysiology is from mechanical trauma, increased pressure, and ischemic damage. So mechanical trauma could be repeated hand movements can cause this. So it is associated with manual workers. However, I'm going to go over the risk factors later, but this isn't the major predisposing factor to have carpal tunnel. The biggest predisposing factor is sex, age, and genetics, and anthropometric factors, and that being the size of the carpal tunnel. So people do think about manual workers as developing carpal tunnel, and there definitely is a connection, but it's not the only factor. And then other factors include smoking, high salt intake, sedentary lifestyle, high BMI, pregnancy or menopause due to fluid retention, diabetes, thyroid dysfunction, high blood pressure, inflammatory disorders such as rheumatoid arthritis, fractures or trauma to the wrist because they reduce the area in the carpal tunnel, sex, with females being more predisposed, and as I had mentioned, anthropometric factors. Carpal tunnel syndrome is the most common entrapment condition affecting one or more peripheral nerves. The prevalence is 4 to 5%, with most commonly affected people between the ages of 40 and 60-year-old. And females are the most often diagnosed with carpal tunnel. And so here we have a graph showing how much more prevalent it is amongst females and males, and it also shows you the age distribution. So you could see that the 45 to 64-year-old age group has the highest prevalence of carpal tunnel. And then it also is associated with work activity. So the prevalence varies across occupations and industries, with industries such as fishing reporting an occurrence estimated at 73% of the workers. So some of the signs and symptoms of carpal tunnel, it begins with nocturnal symptoms in the distribution of the nerve. And the reason for this being is that when you're sleeping, you're maintaining your wrist in a flexed position, and there's a theory that there isn't a musculoskeletal pump that's activated when you're moving during the day. So it allows the pulling of fluids in your wrist, and that leads to inflammation and compression of the nerve. So the nocturnal symptoms would be in the distribution of the nerve, and here you can see in the graph to the right that the digital cutaneous branch goes all the way to the fingers, and the palmar cutaneous branch stops at the palm. So the palmar cutaneous branch is not affected by carpal tunnel because it does not pass under the carpal tunnel. So it is the digital cutaneous branch that is affected, and that is where you will feel the symptoms. And these symptoms can include burning, numbness, tingling, a chalk-like sensation, or pain. And then as the disease progresses, you might get symptoms during the day with prolonged flexion of the wrist, so repetitive movements aggravating the wrist. And then it could turn into weakness and thenar wasting, which is a much later symptom that you'll see. And you can see in this picture to the right that the person has his thenar eminence is really worn down. So that's a pretty late stage of carpal tunnel. So for the diagnosis of carpal tunnel syndrome, we want to be taking a patient history, where we're asking questions such as the frequency and duration of symptoms, if there's the symptoms occurring at day or at night, and positions that may be provoking the symptoms. And then we also want to know if they have any predisposition factors, which I'd gone over earlier, such as diabetes, inflammatory arthritis, and many others. And then we want to take an examination of the involved upper extremity. So we want to be looking at the range of motion of their neck, of their shoulder, and also seeing if they have instability of their shoulder, and then an elbow examination, because conditions here can mimic carpal tunnel syndrome symptoms. And then inspection of the hand. So we want to be checking for abrasions or ecchymosis to the hand, which may indicate damage to the tissue, which can harm the median nerve. And then we also want to check for atrophy, which is a later sign, but you could see wasting. And then special tests. So we want to be taking the grip strength test, just checking their grip strength and seeing if there's any damage to the motor root of the median nerve. Tunelcine, which has a sensitivity of 62 and a specificity of 92, and here we're just tapping the median nerve as it passes under the carpal tunnel. And then reverse phalanx maneuver, where we have the person extending their wrist and their fingers and holding at 90 degrees at about their chest level, and we don't want to be pushing the hands together, just kind of holding there for a minute, and we want to see if that reproduces any symptoms. And then monofilament testing, vibration, and 2-point discrimination can also check for disruptances in the sensory root of the nerve. And then some outcome assessments we could use are Boston Carpal Tunnel Questionnaire, Michigan Hand Questionnaire, and Patient Evaluation Measure. There are other ones, but these are the ones that had the best validity, reliability, and responsiveness. And then some imaging and diagnostic testing. So we could do nerve conduction studies, which are normally done with an EMG, to evaluate motor and sensory nerves. And it gives information about peripheral nervous system with the muscular system, providing real-time information. And then with the nerve conduction studies, we're going to place electrodes over the nerve or the muscle it innervates. So the nerve is stimulated to produce an action potential, and we are looking at the velocity of the propagation. So for carpal tunnel syndrome specifically, we would put an active electrode over the abductor pollicis brevis muscle belly and a reference electrode over the muscle tendon. And if there's a distal motor latency of over 4.2 meters per second or milliseconds, or a nerve conduction velocity of less than 49 meters per second, this is evidence of carpal tunnel. And then within the EMG, which, like I said, is done with the nerve conduction studies, you have to put needles in a patient. So this could be kind of painful. So I'm sure most patients wouldn't like that being done to them. And this isn't really for the primary diagnosis like the nerve conduction study. It's more done to exclude other conditions. And then radiology and CT scans provide static images. And more so for the radiology, it's really just to detect for like tumors or deformities or other bone or joint diseases. And then the radiology and CT are limited since they depict soft tissues with poor contrast compared to MRI and ultrasound. And then the MRI provides high spatial resolution and soft tissue contrast to examine the median nerve. So it displays the overall morphology of the nerve and the cross-sectional area. So if we have a cross-sectional area of over 15 millimeters squared, then that is considered an abnormal finding, and it probably is a diagnosis of carpal tunnel in that sense. And then we can also check for flattening of the nerve and flexor retinaculum bowing. So when we combine all this, it gives MRI sensitivity of 96%, but a low specificity. And then ultrasound is a cheaper alternative to MRI because MRIs aren't cheap and aren't quite as easy to use as the ultrasound. So we'll be going more over the ultrasound later. So some treatment options for carpal tunnel are using a splint, so just kind of holding the wrist in extension to relieve symptoms. And then change of work positioning and making sure that we're not using vibrating equipment. So the positioning, we can improve posture so they're not rounding their shoulders, make the computer mouse comfortable, just keeping in mind that any exaggerated position of the wrist can lead to carpal tunnel. And then we can do therapeutic exercises as physical therapists, so stretches and exercises to increase the strength of the muscles of the hands, fingers, and forearms. And then if that fails, corticosteroids injections can be used. And last case scenario would be surgical decompression. Okay, so now this module is complete. So if you could please go to the website and go to the the quiz tab and take the quiz for this module before you move on to the next, that would be great. Thank you.